So let's get underway for our second session of GVCC21. This one is a conversation that I think will be really informative in that nobody really trains us often to have these conversations. And I know for me personally, the topics can be really tough to handle. And so I know this is a session that I've been looking forward to just to get some insights from my own experience and to learn about the duo, the back and forth relationship between patient and provider. So I am incredibly honored to introduce everybody who has come back and all of you who are with us now for your first session of the Global Virtual Cancer Conference, to introduce Terry Cootie and Dr. C. And Dr. C, I'll have you pronounce your full name when you start. I want to respect it and do it justice. So Terry, it is my honor to hand you the mic.
Dave, thank you so much. And before we get started, I am shouting out to your entire team at Gryt for this amazing, enormous job that you have all done so well at Gryt with this Global Virtual Cancer Conference. Thank you so much for having us tonight. And you know we love this topic and conversation, so we'll get rolling. Thank you so much, though. Really appreciate it. So tonight for our roadmap, and as Dave said, my name is Terry Cootie, and I have known Dr. C for quite some time. So what we're going to do tonight, we're going to, on tonight's event, we're going to talk about how to approach a patient and provider relationship. Dr. C has gathered stories from his life's experience as a physician, and he is going to tell us how those stories changed his practice and why he practices and promotes the shared decision-making model. Myself, I'm a two-time breast cancer survivor, and really my story changed my life's mission. And I'm going to tell you tonight why I now advocate for shared decision-making. With that, I'm going to turn it over to my surgeon, my friend, my colleague, Dr. Minas Chrysopoulou.
Thanks very much, Terry. First off, I'd love to echo what Terry said. It really is an honor for both of us to be here, and the work being done by Gryt and the whole team is absolutely phenomenal. So it's a pleasure to be here tonight, and we're honored for the invitation. All right, let's go on to the next slide. Just some disclosures. So a little bit about me. I'm actually a breast reconstruction surgeon. So my patients are patients who have a breast cancer diagnosis or have had a breast cancer diagnosis, or who have been diagnosed with a genetic mutation that predisposes them to breast cancer. So I reconstruct people after breast cancer surgery and after risk-reducing surgery. I am president of PRMA Plastic Surgery. We are in San Antonio, Texas. Our core service is very much breast reconstruction. It's pretty much all we do. And we have a particular focus on autologous reconstruction, which is using the patient's own tissue to reconstruct a natural, warm, soft breast. As my career has developed, it's kind of expanded beyond the technical aspect of breast reconstruction, and I became very interested in shared decision-making as a means of really improving the care I was delivering to my patients, and we're going to talk all about that tonight. But as part of that journey, the personal growth, learning about shared decision-making, I presumed there were apps out there for breast cancer surgery. Unfortunately, there weren't any, so I put a team together and founded Tolman Health, and we built the app ourselves. That's the Breast Advocate app, and you can learn all about it at breastadvocateapp.com. We also have a booth. Thank you very much, Gryt team. We also have a booth at this conference for you to check out. So So please do. Next slide. So, when I was coming through training, medicine is very much an apprenticeship, right? So we are taught to emulate our mentors, and it's kind of a see one, do one, teach one approach. When it came to interactions with patients, when I came through many years ago, it was quite paternalistic. So the patient would come in, visit with the physician, and the physician would basically explain the options, explain the risks, and then make a recommendation, and that was about it. So that's very much a paternalistic approach, no input from the patient. When I started practice, I didn't think that was really ideal. So I thought patients needed a lot more information. So you start talking about other things, including other things, how the recommendation impacts other aspects of life. You try and be more holistic in terms of the information you're providing, but that informative approach still doesn't take into account the patient's wishes. So shared decision-making, which actually is a new concept, it was first described in the 1980s. Shared decision-making takes the physician's expertise, evidence-based medicine, but it also very much takes into account and requires the patient's input. So the patient's interests, their preferences, their goals, their values, pretty much any factor that the patient deems important in making a decision should be considered in this collaborative two-way street. So the patient learns from the physician or any healthcare provider, and in turn, the patient teaches the healthcare professional what's important to them, and you find the intersect in the middle, as you can see on this Venn diagram, and that's shared decision-making. So you could have twins, two patients, same diagnosis, same genetics, they're twins, identical twins, let's just say for argument's sake. And you could have two completely different treatment plans with this shared decision-making model. Next. So when it comes to breast cancer, which is Terry's and our world and my world, why do we need shared decision-making? Aren't we doing a good enough job, without it? Well, no, not really. This study showed that approximately 40% of breast cancer patients don't fulfill their preferred role in their treatment decision making, right? And so the problem with not feeling you're part of the decision is multiple. It leads to decisional anxiety. It can cause decisional conflict. You're confused. You're not so sure about all the options in terms of what's best for you. Because of this, you often get treatment delays, and all this leads to a poorer quality of life and lower patient satisfaction, and ultimately lower outcomes. Next. Next slide. And in terms of breast reconstruction specifically, only 43% of breast cancer patients feel they make a high quality breast reconstruction decision. And what does high quality mean? It means that you know at least 50% of the facts, and that you choose a procedure that is in line with your personal preferences. So, I mean, pretty low threshold really that we're not meeting here. Next. Good news is patient advocacy is on the rise. thanks to lots of great people out there doing amazing work, such as Terry with her Deep Sea Foundation. Patients are starting to appreciate and realize that they can have a voice. Again, when I was coming through training, patients didn't even know. It was as though they didn't know they could speak up. And some patients still feel that way today. Thankfully, with patient advocacy, people are more likely to find their voice. They're becoming more willing to speak up. And so really that's a one big message for today and for us, is to make sure that people know that you can be as involved as you want to be. And also, to be clear, we do appreciate there's lots of stress with any diagnosis, not just with a cancer diagnosis, any health diagnosis. And sometimes you don't want to really dive into the nitty-gritty, or, sometimes you want your physician to just tell you what they would recommend for their wives. And that's okay too, because that in and of itself, you as the patient are making the decision that that's what you want. That decision is not being made for you. So the degree of autonomy the patient has should be defined by the patient. By definition, that's one of the core aspects of shared decision making. So that's a very important point. Social media also has become a great vehicle for patient advocacy, and it's definitely helping us get the word out about shared decision making. Next. So I touched on this a little bit earlier already. So the benefits of shared decision making, it goes way beyond just education. And it goes way beyond explaining just the risks of a procedure. That's a big misperception, I think, for some physicians. They, when you ask them, "Oh, do you practice shared decision making?" They say, "Yes, of course I do. Of course, I tell my patients all the risks." Okay, what else do you tell them? Why? I tell them all the risks, pros and cons, everything. It's like, well, there's a lot more to it than that, I'm afraid. So it's not just about patient education, but obviously it involves full education. It helps set appropriate expectations. If someone understands and is part of the conversation, then they have skin in the game. They're bought into the decision-making process. That decreases the anxiety associated with the decision. It helps people get to a decision quicker. Patients are happier. And it improves outcomes. And let's not forget that, when things go well, all physicians are the best, right? I mean, in our practice, we often joke, oh, Dr. Nastala is the best. Oh, Dr. Pisano is the best. Oh, Dr. Ledoux is the best. We all have patients who think that we're the best. The best, it's defined by how things go when there's a complication, because everyone's the best when things go well. When it comes to getting through complications, that's when you really need a good relationship between the patient and the healthcare team. And again, a shared decision-making process that provides the buy-in, it really helps deal with complications, because patients remember why they chose the decision that they chose. They knew the risks too, but having the understanding and being part of the decision and having weighed up the pros and cons as they related to them, their lives, their situation, it helps them get through the complications too, if and when they happen. And unfortunately, they do happen sometimes. Next. This is a study out of Germany, and it basically looked at patient satisfaction. Any consultation really that involved shared decision-making was significantly related to increased patient satisfaction. That's all this slide shows. Next. The SHARE approach to shared decision making. This is from the Agency of Healthcare Research and Quality. This is a really good guide. This is actually how I got going in terms of trying to evaluate how I was going to actually guide the consultation with the patient, the kind of steps involved. And this is a really good kind of blueprint. I will say that this is just a guide. The more you do this, the more you realize you've got to be malleable in your approach. You've got to pick up on cues from your patient. You've got to gauge the situation, and it's not always a 5-step process like this. I would say all my consultations involve shared decision making, but they don't all necessarily involve all the same steps. But this is a very good guide to begin with. Next. So, unfortunately, shared decision making, even though it's standard of care, it's not standard practice, and there are a few reasons for that. Physicians feel it's very challenging. It takes up so much time. I've got to get to know what's important to the patient and their preferences and blah. But it really doesn't take much time at all. There are ways to get around the informational aspect of it. We use decision aids, videos, any tech really that you prefer as a physician, you can use to provide to the patient ahead of time, so patients can review pertinent information before they even come in, if they have the time. They can also recap after the consultation and review things. So instead of me spending an hour with a patient going through the same spiel about breast reconstruction options again and again and again, kind of cookie cutter, that doesn't happen. We use the Breast Advocate app, we use videos. Patients often come in and they tell me off the bat that they're not interested in certain things and they're very interested in other things, and they want to hone in and talk about very specific things. And that's where the consultation becomes customized for them. And so shared decision-making actually helps me provide a much better experience. Some physicians feel that shared decision-making is impractical and it doesn't really apply to their specialty. I think that's nonsense. I think shared decision-making really applies or can apply to absolutely any specialty. Financial disincentive, this can be an issue, admittedly, in the US, because if you define shared decision-making as offering all options, then by definition, some physicians won't be able to offer all options and therefore won't be able to practice shared decision-making. I do feel that's a flawed definition. I don't think that is the definition of shared decision-making. Just because you don't offer every single option doesn't mean you can't practice shared decision-making. For us in our practice, we're spoiled because we do offer the full gamut of breast reconstruction procedures. But just because you don't doesn't mean you can't tell folks about other options and offer shared decision-making for the options that are available locally. Next. We go about this in many ways in terms of touch points. We look at the clinical pathway, how the patient finds us initially, making the consultation, coming through the practice, and making a decision, all the way through to survivorship. And so basically, we try to maximize the touch points, and we try to be very cognizant that different things work for different people. So I think the more avenues you offer patients to pursue, the more likely it is that they're going to find a channel that resonates with them. And it's the same information throughout. So we've got the same stuff, same info in a printed booklet that some people prefer, as we do online. Next. Just a little bit about the Breast Advocate app. Irrespective of your specialty, there have to be aids out there, decision aids, tools, digital tools out there that can help. For breast cancer reconstruction, breast cancer surgery specifically, there wasn't anything out there that I could recommend, which is why I created the Breast Advocate app with patient advocates. It was a huge learning experience for me. Terry, again, thank you so much for your input and help. I couldn't have done this without you. But we got a bunch of patients together, different demographics, different experiences, different diagnoses, different choices. So whether they had a lumpectomy, oncoplastic surgery, whether they chose aesthetic flat closure, breast reconstruction, implants, their own tissue, everyone came together to really discuss what's important and what should go in the app. And it was a co-creation with a huge group of dedicated breast patient advocates. And I'm extremely thankful this wouldn't have happened without them. Next. Terry, you're up.
I'm up. Yes. I'm going to say before I get started, I thank you, Dr. C, for mentioning our collaborative work with the Breast Advocate app. I want to begin by encouraging those that are joining us tonight to explore your decision aids for your particular diagnosis, because we all know that there are lots of apps out there, and it will help you improve, organize, and make your partnership with your provider and your care team more meaningful, and it'll honestly make you feel like you're more in control. And I share Dr. C's Breast Advocate app in my own community because of all of those reasons. And I watched this app develop from the very beginning. So what I'm saying to all of you out there is explore and discover some apps. Try them on. If they don't feel right, if they're not comfortable to use, you certainly have options for that. So I shall begin. This is a story behind Deep Sea Foundation. I'm a 2-time breast cancer survivor, and I had to learn about navigating my journey through breast cancer. I was one of those patients, like many of you, who probably felt like you were drinking out of a fire hose some days when you had to take in all of the new terms that you were learning, all of the new treatment options. Besides that, I was navigating insurance, dealing with my own emotional trauma from the diagnosis, and that was twice, mind you. Dealing with my family's emotions, and really all of that encompassed. But here's what I did learn. What I took away was that the recovery was really a huge part of my healing, but it also had a huge impact on my professional life. So here's my story. Next slide. We will click through these, and the first click, if you could click on that, please. So my first diagnosis was in 2002, and I was at a leading cancer center in the United States. If we have any people joining us from around the world tonight, it was at MD Anderson in Houston, Texas. We had 2 young sons at the time, and with them and my husband, we muddled through the stages of cancer from diagnosis, decisions, surgery, chemotherapy, radiation, recovery. Oh my goodness, yes, I know some of you have been down this road. I feel like it really took me about 3 years to return to a place that I was before cancer. That took a lot of work, going back to the gym, just being diligent about, what I put in my body, et cetera, et cetera. And also what I did is I returned to teaching and being an educator. That is the profession I chose, I love, and have been endeared to my entire life. Unfortunately, my cancer returned, and this time you can see me with the thumbs up in the white hospital styrofoam cup just 24 hours after I had a double mastectomy. I knew at my second diagnosis, because my breast cancer returned in my left breast, and I had a new primary in my right breast, that I was facing amputation of my breast. And honestly, I had no knowledge of restoring my breast through reconstruction. But my breast surgeon was well informed, very much in tune with shared decision making, and she gave me all of my options, discussing the risk and benefits of those surgeries. But what she also did is she kind of gave me some qualifications that I might consider for a reconstructive team. Click on the next one, please. And there he is. There's Dr. C in his fancy blue hat. In April of 2014, after a double mastectomy, I began my recovery and acceptance of the loss of my breast. But I knew I wanted to have deep, at the time of my double mastectomy, using my own tissue to reconstruct my breast. I had a voracious appetite for research. It was important for me to find a well-qualified, board-certified plastic surgeon. I found that person in Dr. C, and this is the morning of my surgery. Yes, I made him put the blue hat on for the picture. And 7 months later, after my double mastectomy, I had successful breast reconstruction. Click on the next picture, please. This is when I experienced the true value of shared decision making. After flying back home for my reconstruction, I knew that my life's course was changing. This is when my voice, my work as a patient advocate began. Next slide. It really started out with my story. And when I started writing my blog, it was cathartic, but I wanted it to be with purpose. And that's why I came up with the tagline, Reconstructing a Purposeful Life. 1 year after writing my blog and started sharing it on social media, I got the nudge to open my foundation. And this was really the beginning of our work together, Dr. C and I. I was really pleased that I got that phone call from him, and quite honored that he encouraged me to do this. So I answered the call, and we are both now working to empower other patients to understand and know what shared decision making could do for their healthcare experience. Next slide. The foundation was born in 2016 out of my patient voice, because we each have one. And that's what I appreciate about Gryt, is that they honor the patient voice. What I realized, it was just one story, one voice. And now that was going to become thousands of voices. So what I did for the foundation, I began building what I often call a 24/7 library of resources to empower patients through their own personal decision. These are some of those decisions, the decision aids that Dr. C was talking about earlier, that I have built through the foundation. So you can find me on Twitter at 6Date. That's my original Twitter handle when I was in teaching. I had teaching certificates in 6 states, so I hope there's no confusion there, but I kept it and I own it. On Instagram, I can be found at Deep Sea Foundation, same on Facebook, same on YouTube, and on LinkedIn, you can find me at Terry Kuti under my name. I think there's great value in connecting on social media, especially these days. And if you could go to the next slide, please. The true silver lining for me this year through the pandemic was launching the podcast Deep Sea Journey. And I guess I just wanted to be Gryt when I grew up and have a year-round virtual conference. So I started the podcast. But all of these were set up really to empower patients as I became more and more involved in promoting the shared decision-making model. Next slide, please. So I don't collect data. We all know data is important for our, outcomes, what we're studying, what the impact is of all of this. I don't collect data. I'm not a researcher, although I research every day. I run a nonprofit that serves people from around the globe, plain and simple. Those people that are affected by breast cancer. You don't know what you don't know, though, right? So I provided those resources. I provide those resources daily in collaboration with other healthcare clinicians who are genuinely passionate about educating the patient, like Dr. C and many of his other colleagues. We should be sitting at the table with them, collaborating for patients to understand and activate the shared decision-making process for patients. What questions should we ask? Knowing procedural terms, understanding risk, discussing recovery, and how to return to life after a diagnosis. So again, I don't collect data and do published research, but what I hear, you guys, is feedback. So this is a comment I received recently from a trained plastic surgeon who reached out to me in a message on Instagram. And I invite each of you listening today, if you are but one voice, be that advocate of change. We can do this one patient at a time. This doctor said, we had the opportunity to take care of a patient Terry was in touch with about her upcoming DEEP flap through the Deep Sea Foundation. She was so knowledgeable about everything regarding her surgery. It made coming with a shared plan together so easy and fluid. You guys, that's what shared decision making is about, changing this for one patient at a time. So help Dr. C and I share the message that patient education really does foster patient engagement. This is shown through studies and through my own work in nonprofit leadership to make a difference. We need, and I'm talking to you audience, all those out there, we need to amplify this message. Sharing our own experiences, good and bad, to improve outcomes for patients and improve our healthcare system. It is incumbent on all of us to move forward and to move toward making shared decision-making, just as Dr. C said, a common practice, enabling patients to become partners in their cancer care. Next slide. So what we're going to do tonight is put this into action. And with the help of Dr. C, we're going to do a little role-playing session. So what we're going to do in this lively role-play session, we're going to hear from a patient and physician, that would be both of us, as they model different scenarios to help us all navigate the sometimes tumultuous relationships of patients and healthcare providers. And we're going to leave this session tonight with insights that we can all apply to our interactions with our own medical team, turning what once made us feel powerless into power. So, Dr. C, do you want to set up the first role play? I think we can stop slide sharing now. All right. Are you ready to go?
All right, let's do it.
Let's do it. Let's set up the scenario first. Shall I call you Dr. Paternalistic?
Sure, why not? I'll do my best to be paternalistic.
I know it's hard for you. That's not in your nature.
This can be good.
Okay, let's do it.
All right. So do you want to? So just to set the scene, because obviously we can't do a full consultation. We want to kind of just give like a snippet to get a general idea. So you are a newly diagnosed patient, newly diagnosed with breast cancer.
Yep. Haven't had any surgery.
No surgery yet. You're also a gene mutation carrier.
Yeah.
Okay.
Yep.
So you've met with your general surgeon, and basically you've decided you want a double mastectomy because of your gene status and cancer diagnosis. And you've already decided that you're interested in exploring breast reconstruction.
Yeah.
Right. So that's the
background. Shall I open the door and start the consult?
Sure. Open it up.
All right. So wow, I've been sitting in the waiting room. Okay. I can hear him walking down the hall. Here he comes. Door opens. Hey,
hello.
How you doing?
Hello, Mrs. Kuti. I'm Dr. Chrysopoulos. Lovely to meet you.
Nice to meet you.
I've reviewed your chart. And it appears you're here to discuss breast reconstruction. Is that correct? Okay, well, great.
Yeah.
Well, you've got some good options. Implants are the most common technique that we use.
Okay. Well,
lovely reconstruction with implants.
Okay. Okay. Go ahead.
So it's usually performed in my practice as a 2-stage procedure. So we use temporary implants called tissue expanders first, and we'll put those in at the same time as the mastectomy. So you'll wake up with breasts. They'll be different, but you wake up with breasts. And then later on, you'll need another surgery to take out the temporary implants, the expanders, and put in the final ones. And those will give you the nicest final cosmetic result.
Well, I've talked to a lot of friends of mine, and I know a lot of women do implants, but I really was hoping I could use my own tissue.
Well, that's a very big procedure. The recovery is really tough, and I don't offer that procedure, but it's a very big surgery, and implants do great.
Why is it such a big procedure over the other one? Surgery, right?
Very long, and you've got to be in the hospital for a long time, and a lot of people need to go to the ICU, it's the recovery is really it's really very tough. And I don't offer those procedures, but really they're very, very complex and difficult to recover from. And you can get a lovely reconstruction with implants. We do it all the time. And it's really, most women get implants, tried and tested, and they're very natural feeling, can be very soft, nice, soft.
But somebody told me once they might be a little cold. I run really cold. Is that, I don't know.
That's not really been a general complaint that I've heard from my patients, no. So time is ticking, and we really should make a decision and get you scheduled because...
Well, but Dr. C, I'm kind of confused now because I really came in here to talk about using my tissue, and I feel like I kind of need to make a decision now. Should I go get a second opinion maybe? Or
I think I think that will really delay getting you into the OR and getting you taken care of. I really would recommend that we just kind of get on with things and get the insurance issues sorted out and get you scheduled. Why don't we have my nurse follow up with you and we'll get things moving, get you taken care of. Okay. All right. Well, lovely to meet you.
Okay. All right. Well, thanks. I'll think about all this.
Thank you. Bye-bye.
Bye.
God, that was horrendous.
I'm wringing my hands here. Dr. C.
That was pretty paternalistic, right?
But I'm looking
appropriately awful.
I hope so. But listen, I want to tell you, because while you were giving your presentation, I was looking in the chat.
Yeah.
And there was comments on there that people felt this way. They felt dismissed and hurried. And all right, so let's go into this good one now. Let's
that was a really good, you made some good attempts trying to tell me that, I felt you tried very hard to interject your point that, you weren't feeling good about the information you were being given, that you needed more. You pushed the tissue very well and you were completely dismissed.
Mm-hmm.
At least you wanted to talk about something and you weren't given the time of day, right? Mm-hmm. And so and I want to highlight the second opinion issue, mm-hmm. because second opinions shouldn't be taboo. Second opinions should be readily offered. If you experience something as horrendous as what we just did, you've got to get a second opinion, okay? Because any physician who doesn't support the patient in getting a second opinion isn't comfortable and confident in their own self, and that's my opinion, right?
Yeah.
And also, it should be, if possible, it should be transparent, because I recommend second opinions fairly frequently, I have to tell you. Right?
Well,
but I know who's good, and I know whose opinion I respect.
Yeah.
And so, patients don't always, they don't have the time, they don't have the back end knowledge of knowing mm-hmm. who does a lot of each procedure. And, and second opinions can also often validate the first opinion. So it doesn't mean that the plan's going to change. It's just extra validation. So second opinions never hurt. And I encourage people, even if they think about it just for a split second, do it.
Yeah, I have to tell you, it wasn't in the case of my reconstruction. It was another part of my whole diagnosis. I had to get a second opinion. And what it did, it gave me clarity.
Yeah.
It gave me clarity, and it validated what I had looked up. My second opinion didn't tell me I was right or wrong. They said, what you did, your research was good. In consideration of your own quality of life, I completely support you coming in here to get a second opinion. And so, yeah. So I'm going to say something really quick, because I'm going to have the wonderful people at Gryt put up a blog that you and I just wrote together. And I don't want to be presumptuous about anything here, but somebody in the chat room said, how do you get your surgeon to sign on to shared decision making? Well, there's a no judgment zone here. We know that everybody's different. We know that patients are different. We know that physicians are different. And it's a hard transition for some people to buy into this whole process, both patients and physicians. But I'm just going to say, take that blog we wrote, mm-hmm. print it up, And before you even go to your consult, and if you call them up and say, do you guys practice shared decision making? And they go, what? And say, well, can I send you some? I've got my name on it. I'll claim stake to whoever wants to shout out to me and say, well, who is this person? These are tips that you and I are going to provide tonight. And we're going to kind of model this in our next session. But honestly, take this blog that they're going to put in the chat room, whoever's watching tonight, and please utilize this. Dr. C and I worked hard to try to really bullet item some things that both the patient and the clinician can use. So you ready to go with role-playing number 2?
I'll make one more point about the bad scenario that we just did. And I think few people feel comfortable doing this.
Mm-hmm.
But if it's in you and you have the personality, there's a very civilized way in which you can call out your physician or healthcare professional, whoever it is. You could literally say, look, let's put the brakes on. This consultation isn't going very well for me.
Mm-hmm.
I'm afraid to say. I don't feel I'm being heard. And then you just explain, right? You can be very civil. I completely understand that not many people will feel comfortable doing that, and they'll consider it too confrontational and what have you. I just wanted to throw it out there that can often be a reset that's very powerful, mm-hmm. and actually be the beginning of a phenomenal relationship after getting off on the bad foot, right? Doctors have bad days too, guys. Okay?
Oh gosh, yes.
Right, and there are times when you've just spent an hour and a half with someone that was supposed to be a 15-minute visit because it was just a quick follow-up, and unbeknownst to you, they've now got a new cancer diagnosis that they've just found out about, blah, blah, blah. It takes on a life of its own. You can't just leave that person. Mm-hmm. So now you are so far behind in your clinic, right? And so as a human, right, we're just trying to get through the day too, to a certain degree, right? And sometimes we just don't put our best foot forward for whatever reason, right? I'm not making up excuses, but sometimes we need a reset too, right? Mm-hmm. So anyway, just thought I'd throw that out there.
Yeah. And one of the things that I put in that blog too, for me, when I had to go in and confront one of my care team one time about something that did not go well for me. Mm-hmm. I literally sat at home and visualized that. When I knew I had to talk to her, I was a wreck thinking about even doing it, because here she is, a trained physician. But I had to practice. I practiced that at home. I wrote down bullet notes. I scripted it out, and I sat there and practiced it until the day that I went in to see her. I sat there and took a deep breath, and I said, "Doctor, there's something I really need to talk to you about." Mm-hmm. And just saying that caught her attention.
Yeah.
So.
Yeah.
Yeah.
Good points. All right, should we do scenario 2? Because Dave's going to kick us off.
Yes. Let's do it. All okay.
Right. So same diagnosis,
same diagnosis,
picture and everything. Newly diagnosed with breast cancer, gene carrier, no surgery. You want bilateral mastectomies, and looking to discuss your options for reconstruction.
All right. Opening the door.
All right. Scene 2. Hello, Mrs. Kuti.
Hi, Dr. C. Nice to meet you.
Nice to meet you. I'm so sorry you have to be here for this. We're going to get you through it, okay?
No, thank you very much. I appreciate it. Just dealing with this diagnosis has been enough. So I'm here to talk about having breast reconstruction, and I've heard good things. So I'm ready to see what you have to tell me.
Absolutely. Well, I've reviewed your chart, okay, and I've got a very good idea about what's going on medically speaking. But why don't you tell me in your own words, your thoughts coming in today, kind of where you are, if you've had a chance or have done any research of your own. Why don't we start there? What do you know about breast reconstruction coming in today?
Well, I had a really good breast surgeon, and she told me about all my options. She told me about implants and, what that involves. She gave me a lot of brochures, and she said, take it home and think about it. But it was really weird when we're sitting there, because she said, well, did you know you can use your own tissue? There's something now it's considered a gold standard, and they call it deep flap. And I said, I have no idea what you're talking about. When she described it, I don't know, it's like the earmuffs went on for me. I took all this stuff home about implants, but when she told me I could use my own tissue, I don't know. I already had a mindset, I think, and I really started researching that. And I went on some websites, that are, I think they're trusted, PubMed, and I actually even looked at your website, because you have a lot of resources on there. You have a lot of blogs and some studies and stuff, and talked to a couple of patients that, I knew that had been through this. And I talked to my breast surgeon again, and I'm comfortable. I am here to talk about having deep flap. So,
okay. Well, so let's backtrack a little bit just to make sure that you understand all the options. So the most commonly performed procedure in the country uses breast implants. You're absolutely right. There are other options, not just the deep flap, but several flap options. So when you use your own tissue, that's called a flap.
Okay.
So flap options, but and there are pros and cons to each. You can get a very nice reconstruction irrespective of the procedure you choose. What is it about using your own tissue that appeals to you?
Well, I've always been kind of a purist, kind of watch what I put in my body when I eat and all that. So that whole line of thinking made me think, well, if I use my own tissue, it's more natural. I'm not having something foreign in my body. And okay, I'm just going to go right straight to the old. I had two really big boys, and my breast surgeon was teasing me. She says, well, you can use your tummy for your boobs. I was like, wow, that's pretty cool. But I don't even know if I'm a candidate for deep. And that's really why I'm here to see you today.
Absolutely. What are you doing for work right now?
Well, I am actually I went back to school to get my master's in teacher leadership. So I'm just like full blown studying right now and trying to plow through all the work that involves. I've taught school all my life, and now I want to do something different and mentor other teachers. So I'm full blown student myself.
And would taking some time off to recover from surgery be a problem, or is that an issue?
Well, I did talk to my professors, and they have been so nice to accommodate like my tests, for my finals and stuff, and to give me extensions. So I've already been in contact with them, and I think that I can make those arrangements with them. But I'm glad you asked me that, because it was a concern of mine, So yeah, I think that I can.
And who do you have at home to help you get through all this?
I feel so lucky, because my husband's going to be there, and my two boys, they're on board. They saw me go through this the first time, so they're like, Mom, whatever you need, we'll be there. I've got family that said they would fly in, but I've got my core team there, and so yeah, I feel well taken care of and really lucky in that regard.
Okay, great. So you'll be able to delegate some things to them in terms of groceries and cooking and that kind of stuff.
Yeah, I can be bossy.
Yeah, yeah.
They're great. Yes, I can. They've all agreed to help out a lot, and I feel comfortable.
Good, good. And what sorts of things do you do activity-wise for fun, perhaps? What is it that you're eager to get back to? What's important to you in terms of getting back to after all this?
Well, that was kind of a big concern for me because, I mean, before I flew here to see you, I was at the gym last week, hardcore working out, elliptical machine. I like to do weights. I love to do walking. I'm my father's middle child, and he always told me, God rest his soul, that I was the son he never had. So I'm kind of active. I've always been in sports, and I'm a little bit concerned about this surgery and, the recovery and everything. So what's that going to be like?
Well, we'll definitely talk about all that. Let me step out and see if you're a candidate. Let me have you get changed down, and then I'll come back in and we'll do the physical exam. And then after that, once we've seen that you're a candidate for the procedure, we'll talk about all the risks, all the recovery, everything you need to know. And then we'll make a final decision together as to whether we think this is the best way forward for you. But based on what you've told me so far, I think it's definitely something that we should explore.
Okay, well, I'm feeling a lot better. I feel relieved because just dealing with this diagnosis has been enough. So thank you a lot for kind of listening and pointing all that stuff out to me today.
You're welcome. Okay, I'll step out, let you change. I'll be right back.
Okay. Thanks, Dr. C.
You're welcome. That was a bit better, wasn't it?
Yes. And boy, I don't know. Do we have people in the chat room that are talking? I've been so involved in, oh man, I felt like I was back in your office, Dr. C. That's exactly how it went for me. I wish it was like that for everybody. So do we have questions that we need to answer?
I don't know. I should make this chat box bigger.
No, it doesn't look like we have questions and stuff.
Dave is back.
Yes, Dave is back, and you know what?
And we've run long.
I'm going to shout out to the team again. I can see they've been answering questions. Thank you, guys.
I don't know if you could tell, there was moments, many of our team are here together in person, when we laughed out loud during some of the points you were making. You really had an impact on us.
Oh, well, cool. Great. Please remember, the first doctor was not really me. Please.
Manas, even when you were pretending to be that doctor, you still came through with your authenticity. So we know that. We know that. Terry, I would love to ask you, for somebody who's undertaken this journey personally and now helps others, what is it like for you to look back at how you had to find your voice and now you help others? And I'm just watching you, I'm in awe. I'm just curious what it's like.
Dave, I'm really glad you asked me that. Dr. C and I had this conversation, what was it, 2 days ago? I don't know, Dave, what brought me to this point. All I can tell you is that I know I'm supposed to be here. I was so fortunate the way I was brought up and the values that my family and my parents instilled in me. But if I didn't take what was given to me, my fortune, even through 2 diagnoses, and give this back to all those other people that are going through this, who were so confused like I was, who frustrated with misdiagnosis, dealing with treatments, I wouldn't be worth my weight in gold. And so I don't know how I got to this place, Dave. All I know is I love it and I'm supposed to be here. That's what I know.
And we never know when we affect somebody's life, what that will mean to them further down the road. And I feel you doing that, affecting people's lives.
Well, I really appreciate that. And, you know, for those that are watching tonight, you don't have to start a foundation through a wonderful influence by your surgeon. You can be the voice for one other person. You can be the voice for 4 other women, 4 other friends. You can be the voice for 5 women and men sitting in a room who are asking you, how do I get through this cancer diagnosis? That's being a patient advocate. It is. So I feel lucky that everything just evolved for me the way it did. But if you're out there tonight on this wonderful conference and you talk to somebody who calls you tomorrow, you've been a patient advocate.
Dr. C, I have to ask you, the most meaningful part of my work and building Gryt is when I see people find their voice and then use their voice and the transformation in them, what that means to feel empowered. What is it like for you to inspire that in so many?
It's really cool, actually, to tell you the truth. I mean, yeah, Dave, you know, you go through all this training as a physician, you follow your passion, you know, becoming a surgeon, all that stuff. And then, yeah, Terry and I have spoken about this at length. You know, you're still fairly young when you finish. You're trying to, you know, prove yourself to the world and do good things and, you know, all this kind of stuff. And you kind of get lost a little bit and you become a glorified technician for a while. And maybe not that great a doctor, you know. And then you kind of mature. And then other things take on bigger meaning. And then the technical the technical expertise and excellence that you always strived for now is relegated to being just a part of what you feel you need to do. And then also, you know, you start, after you've been doing it for a while, you start looking at, you know, fulfillment and legacy and giving back. And you know, I surgically, I touch, I don't know, 200-300 women a year, maybe. I don't know. But this work now allows me to touch way more. And so, I mean, I am morally obliged to do it. Right. And thank you for empowering me to do it through all your efforts. So our lives and goals are intertwined, my friend, and I very much appreciate it.
Beautifully said. You both just spoke so eloquently about purpose. And anytime I feel like we can bring humanity to people that may have lost it from a diagnosis or not feel it, that to me is purpose. And you both brought that so beautifully, and I feel it. So with all of our heartfelt thank you for this session. Thank you so much. And also, not just for all of the individuals that are with us here live, but these sessions become recorded versions on this platform. So if anybody watched this and wants somebody else to hear Dr. C and Terry's words, it'll be here. So please let folks know they can come back and watch anytime. And we look forward to sharing with others what you shared tonight. Thank you both.
Thank you so much.
Thank you so much for honoring the patient voice. Thanks, Dave.
Thanks,
Dr. C.
Thank you both. So just to wrap up in our last few minutes, It was a relatively short start to the Global Virtual Cancer Conference this year, but I can't think of two more powerful ways to get it kicked off. So thank you to everybody who joined us here live. Depending on what time zone you're in, you either stayed late or really late to be a part of this. So thank you for being so present and for all the comments in the chat. We will be back again live tomorrow morning. The virtual doors open at 10:30 a.m. Eastern, and the first session will kick off at 11:30 a.m. Eastern. You're free. We encourage you, would love you to navigate around the platform and look at all of the resources and exhibitors and content. There is great chat rooms to meet each other and have conversations. And tomorrow we'll spend some time getting everybody comfortable and showing what some of the platform can do. So from all of us at Gryt Health, all of our sponsors and partners, thank you and have a beautiful evening.